Hi, I'm Tracy Vink,
And I'm Shanna Lewis.
and our Joint Commission National Patient Safety Goal is preventing mistakes in surgery.
Okay, so what is a surgical error? A surgical error is an unintentional preventable injury occurring in the perioperative period that is not considered a known acceptable risk of surgery and could have been avoided by following appropriate procedure specific training protocols. Down below here, we just have a headline of a recent surgical error that led to a poor patient having his leg amputated after a knee surgery.
Okay. Here we just kind of have a slide of our surgical errors, like the common surgical errors, re recover for your injuries, of like what you would experience if there were an error in your surgery, and then how to avoid mistakes.
Okay, and common errors in surgery, we have retained foreign bodies, mislabeled surgical specimens, the wrong site, the wrong procedure, and the wrong patient.
Factors leading to errors. They kind of go hand in hand. There's multifactorial causes such as miscommunication, unnecessary or emergent procedures, insufficient training, provider burnout. Those kind of are what leads to the common mistakes or errors in surgery. Um, and then here we have down in Florida, the Walton County Sheriff's Office moves to next phase of investigating wrong organ removal.
What happened in that case is a patient went in for a splenectomy and the surgeon removed his liver instead, and the patient ultimately passed away. Okay, some surgical error statistics. So in 2021, the CDC recognized medical error as the fourth most common cause of death based on reported mortality when including system errors in the analysis. According to the World Health Organization, over 300 million surgical procedures are performed each year worldwide. And 10% of preventable patient harm in healthcare was reported in surgical settings. And more accurate numbers specific to surgery mistakes, unfortunately, were difficult to find.
Most of them kind of explained more so like just like medical errors in a whole as a whole. It didn't really, give a specific number to the actual surgical error statistics. So it was kind of hard to find. We did find a lot on like the law office websites for like malpractice, like suing for malpractice. Those would give more numbers. It was like 4,000 um, a year surgical errors in the United States alone, but those were also law office websites that we chose not to take that information from because we didn't know if they were quite accurate. Types of errors in surgery. The medical error is an unintentional act, either by omission where an action is not taken, or commission where the wrong action is taken. An adverse event, preventable or unpreventable injury directly caused by medical management and unrelated to any underlying medical conditions of the patient. It does not meet the standard of a sentinel event. There's also negligence, medical care that fails to meet the standard of care as defined by the care provided by a reasonable clinician sharing similar specialty training, knowledge, and experience. A near miss is an unplanned event that almost occurred and had the potential to result in patient harm. This analysis enables healthcare systems to identify and modify protocols before patient harm occurs.
Okay, so continued on the types of error. The never event is commonly referred to as a serious reportable event. It's an error in healthcare delivery that is easily identifiable and preventable and results in severe consequences to the patient. These events identify issues in the care provided and the credibility of a healthcare facility. A sentinel event is an unexpected event, including the loss of a limb or death, causes severe psychological, financial, or physical harm. It requires immediate investigation and includes wrong patient errors, retained foreign bodies, administration of incompatible blood, and incorrect medication administration. A root cause, a fundamental cause for the occurrence of an undesired outcome. Common root causes of sentinel events include, but are not limited to, human factors, poor communication, and leadership.
Um, the repercussions of surgical errors is just kind of a little handful. The bases that lead more into depth, but they create a heavy financial burden for the facility and the patient and family because it could result in a loss of job for the patient. It could cause the family to miss work. You can end up having, no income and ultimately losing their homes or whatever it may be. Um, the hospital has a risk of ruined reputation for facility and healthcare staff. Patient complications such as bleeding, infection, tissue and organ damage, and death. Legal consequences such as malpractice suits, termination of licensure, and criminal charges for the provider or the surgeon and or the staff. And some errors are often covered up and not reported, leading to further repercussions.
Okay, so the Joint Commission is an independent nonprofit organization created in 1951 that accredits over 20,000 healthcare organizations in the United States. Their mission is to provide quality healthcare, prevent patient harm, and improve patient advocacy. In 1998, following a review of a sentinel event alerts related to wrong site surgery, the Joint Commission made an effort to eliminate this issue by creating the National Patient Safety Goals and a universal protocol for preventing wrong surgical patient errors. The National Patient Safety Goals includes the Universal Protocol for Preventing Wrong Site, Wrong Procedure, Wrong Person Surgery, and consists of three main protocols.
Okay. The Joint Commission National Patient Safety Goals to eliminate errors in surgery include to use a minimum of 2 patient identifiers to confirm patient identity, which most often is the patient's name and date of birth. Identify and reduce risks to patient safety. Prevent infection using hand hygiene guidelines from the CDC or the World Health Organization. Ensure medical equipment is functional and alarm systems are in working order and audible. Maintenance must be performed promptly. Marking the correct surgical site on the patient, verifying the correct surgery is performed on the correct patient, and taking a brief pause before beginning surgery to ensure an error has not been made. Ensure medications are labeled correctly, perform accurate medication reconciliation, spend more time with patients on blood thinners, and provide written instructions on their medications prior to discharge.
Okay, the Joint Commission Universal Protocol for Preventing the WSPEs. This protocol is broken into three main categories. The first goal is to conduct a pre-procedure process. Confirm the correct procedure, patient, and surgical site. Involve the patient before receiving sedative medication if possible. This was noted to be one of the most effective steps in the protocol. Identify the instruments needed for the procedure and utilize a standardized list to confirm the availability of instruments needed for the procedure.
Protocol categories continued. The second protocol would be to mark the procedure site. Minimum requirements include marking the operative site if there is more than one possible location that can be operated on. The operative site should be marked by the surgeon and confirmed by the patient in the preoperative holding area. When surgical marking sites are anatomically difficult or impractical, use your organization's protocol to ensure the correct surgical site is operated on. Examples include different limbs, fingers and toes, lesions level of the spine, and organs. If a bilateral site is being removed, such as tonsils or ovaries, the site does not need to be marked. Site marking may be delegated to an individual meeting these qualifications and is done using the same marking throughout the hospital.
Okay, protocol categories continue. The third part of the goal, perform a timeout before the procedure. The purpose of the timeout is to conduct a final assessment that the correct patient, site, and procedure are identified. Some believe the timeout is important to do before the anesthesia to include the patient. Some hospitals have only one timeout, while other hospitals have multiple before and during. A standardized timeout must be performed before making an incision or starting an invasive procedure. The timeout involves introducing each member of the operative staff, such as a surgeon, surgical tech, anesthesia team, circulating nurse, and the patient if possible. The surgical staff must agree on the correct patient identity, site, and procedure. Other items discussed include patient allergies, preoperative antibiotics, or other medications, and the American Society of Anesthesiologists classification. If a patient is undergoing multiple procedures and the provider is performing the procedure changes, an additional timeout must be completed before starting the following procedure.
Roles of the nurse in the surgical setting. Nurses are essential in the surgical setting because they monitor patient vital signs, surgical sites. They change dressings and monitor like the level of saturation in the dressings to see if the patient is in danger of hemorrhage or um, any kind of other issues. They administer appropriate medications and fluids, ensure all necessary steps are taken before and after surgery, including setting up the patient's care plan. They provide patient education, assist surgeons during surgery, and they document all aspects of surgery efficiently and accurately.
Okay, so here we have an example of a surgical timeout. This is from the Overlake Medical Center in Michigan. So we'll play this quick little clip for you.
Hi, I'm Dr. Tom Stoll. I'm an orthopedic surgeon here at Overlake Hospital. The video you're about to watch is a demonstration of the example of a surgical timeout. Here at Overlake Hospital, we're committed to patient safety. The surgical timeout is another opportunity for all the team members involved in the surgery to participate in the patient's safety prior to surgery. Thank you for watching. All right, let's do a timeout. Can we see the consent form?
It's right here.
The consent form reads, Jane Doe, date of birth 9/21/1960. She's here for right knee degenerative arthritis to undergo a right total knee replacement. Do we agree this is the correct patient? Yep. The right knee is the correct knee? Yep. Very good. This is the right knee. It's well marked by myself. Are the antibiotics in place?
Yep. Her patient allergy is for penicillin, so she got 900 clindamycin about 30 minutes ago.
Very good. Her starting hematocrit is 41. She has typed in screen. Estimated blood loss will be less than 500 cc's. A beta blocker is not necessary.
Nope.
Nor is a finger stick blood glucose this time.
Nope.
She has an SCD with a non-operative side and a warming blanket in place?
Yep.
Very good. Implants, instruments are available.
They are.
The imaging is displayed. Very good. I'm Dr. Stoll, the surgeon.
I'm Allison Cromie, the PA.
Vince Frenas, anesthesia.
Adrian Hagen, surgical technician. Sarah Hall, RN.
Thank you. This young lady is in all our care. If anybody has any questions, comments, or concerns, please bring them up at any time. Thank you. That was a simulation of the surgical timeout. Remember, each member of the operative team has a responsibility to patient safety, to participate in the timeout, and to speak up if they have any concerns. Remember, make time for the timeout.
Okay. This sometimes closes out of the hole. So we decided to take a video off of YouTube because Neither one of us has been through our surgical clinical experience yet, so we weren't able to identify what the surgical like setting is that we went to, what they would do, how many timeouts they would do. So we just kind of use different resources. Here is a slide of our resources. And thank you. We hope you enjoyed our slideshow.
I hope you found it very informative.